Welcome to today's edition of the Type 2 Diabetes Examination Room. I'm Dr. Mintz, Associate Professor of Medicine, George Washington University Medical Center, Washington, D.C. The discussion today focuses on the treatment of adult patients with type 2 diabetes at the point when combination therapy is being considered. It is a part of a series of programs that take a close look at the data supporting treatments used in clinical practice. Our expert panel joining me in the studio and via satellite is Dr. John Steinberg, internist, private practice, volunteer faculty at the University of Maryland School of Medicine, Towson, Maryland. Dr. Brad Wallum, clinical assistant professor of medicine at the University of Washington School of Medicine and private practice, endocrinology and diabetes, Seattle, Washington. And Dr. Charles Schaefer, assistant clinical professor of medicine at Georgia Health Sciences University, Augusta, Georgia. This panel will be presenting key data related to Kombiglyze XR and important safety information, or ISI, in what we hope to be a thorough and informative discussion. This program is sponsored by Bristol Myers Squibb, or BMS, and AstraZeneca. Dr. Steinberg, Wallum, Schaefer, and myself are paid consultants presenting on behalf of BMS and AstraZeneca and are presenting information that is consistent with Food and Drug Administration FDA regulations and guidance and the U.S.-approved full prescribing information for Kombiglyze XR. I'd like to begin our program, Clinical Perspectives on Selecting a DPP-4 Inhibitor in Adult Patients with Type 2 Diabetes Requiring Combination Therapy, with a very brief overview of the epidemiology of Type 2 diabetes in the U.S. population, the pathophysiology of this disease, and current treatment guidelines. But first, as I've already mentioned, Kombiglyze XR. Dr. Schaefer, perhaps you could review Kombiglyze XR's prescribing information for our viewers.
Absolutely. Many of you are already familiar with Kombiglyze XR, a powerful pairing of saxagliptin and metformin hydrochloride, extended release. Kombiglyze XR is a combination of a dipeptidyl peptidase 4 or DPP-4 inhibitor and an extended release biguanide. And it's indicated as an adjunct to diet and exercise in order to improve glycemic control in adults with type 2 diabetes when treatment with both saxagliptin and metformin is appropriate. And let me remind you that Kombiglyze XR should not be used for the treatment of type 1 diabetes or diabetic ketoacidosis. You should also be aware that Kombiglyze XR has not been studied in combination with insulin, nor has it been studied in patients with a history of pancreatitis. One note here, there's a boxed warning for lactic acidosis when using Kombiglyze XR. The potential for lactic acidosis is a warning that goes with products containing metformin, and it's a rare but serious condition that can occur due to metformin accumulation. Sepsis, dehydration, excess alcohol intake, hepatic impairment, renal impairment, or acute congestive heart failure may increase the risk for lactic acidosis. The onset of lactic acidosis is often subtle, with patients presenting with nonspecific symptoms such as malaise, myalgia, respiratory distress, increased somnolence, and nonspecific abdominal distress. The lab abnormalities include low pH, increased anion gap, and elevated blood lactate. If you suspect that a patient has acidosis, discontinue Kombiglyze XR immediately and hospitalize the patient. We'll discuss Kombiglyze XR's safety information in detail as we move forward in the program. We will provide additional safety information throughout the presentation. So Dr. Mintz, why don't you begin?
Thanks, Dr. Schaefer. I think we're ready. Let me start with what I consider an important statistic. As of 2010, over 11% of the U.S. population 20 years of age and older have diabetes. That's an estimated 25.6 million adults. Add to that the fact that only 72.9% of all diabetes cases are diagnosed. And of those individuals, 90 to 95% have type 2 diabetes. 90 to 95%.
In addition, over the next 40 years, the prevalence of diabetes in the U.S. is expected to rise considerably. The number of people ages 20 years and older with diabetes has been predicted to grow to more than 28 million by 2020 and to over 47 million by 2050. Can you imagine? This is a near doubling of the diabetes population.
Unfortunately, almost one-half patients treated do not have glycemic control, according to data from the National Health and Examination Survey in 2003 and 2004. To be precise, the survey revealed that 43% of treated patients with type 2 diabetes did not have glycemic control, which was defined as an A1C of less than 7%. In fact, if we consider the algorithm for glycemic control proposed by the American Association of Clinical Endocrinologists and the American College of Endocrinology, or ACE, which is an A1C goal of 6.5% or less, that 43% may be a significant underestimate. I think we all recognize the large gap between treatment guidelines and actual clinical practice in the management of type 2 diabetes, and agree there's an apparent need to improve glycemic control among the U.S. population. The question remains, how do we approach that? Dr. Wallem, maybe you can help with some background on current treatment guidelines and how to implement them with our patients.
I hope so, and I'll certainly try. Both the American Diabetes Association, ADA, and the ACE guidelines address the issue of achieving glycemic control. Both guidelines recommend patients adopt lifestyle and diet changes and also propose assessing and modifying treatment every 2 to 3 months. Looking at the graphic, you can see the guidelines side by side, which highlights both similarities and differences. Both sets of guidelines recommend pharmacotherapy in combination with lifestyle modifications at the time of diagnosis, with metformin being the cornerstone of therapy. And in both guidelines, treatment modifications include the use of combination therapy. Looking a bit closer, the ADA algorithm recommends the use of a stepwise approach to target glycemic control, including the use of combination therapy when the maximum dose of metformin monotherapy plus lifestyle changes do not achieve or sustain glycemic goals. But the ACE algorithm recommends initial monotherapy only for patients with an A1C between 6.5 and 7.5%, also in combination with lifestyle modification. And for those patients within this group who do not achieve the A1C goal of 6.5% or less, combination therapy is recommended at the time of reevaluation. Initial combination therapy, including metformin plus a DPP-4 inhibitor, is recommended by ACE guidelines for those patients with an A1C of 7.6% or more. Finally, here is something to keep in mind. Early diagnosis and lower glycemic levels at the time of initial anti-diabetic drug therapy may be associated with lower A1C levels over time.
Something to think about. Certainly. Thanks, Dr. Wallem. Achieving glycemic control is not easy for many reasons. One big factor is the progressive nature of this disease. In the early stages, as insulin resistance rises, there is a compensatory increase in insulin secretion and glucose levels remain normal, or what we call normoglycemia. But in the long term, as beta cell dysfunction worsens, insulin levels decline. This effect, coupled with an increase in insulin resistance, results in impaired glucose tolerance and hyperglycemia, which develops into type 2 diabetes. The other key factor is the patient. The many influences on glycemic control, such as diet, exercise, and stress, can feel overwhelming, and patients may control only a few on a daily basis, letting others slide. As healthcare providers, we play an important role in formulating a plan along with patient, family, and other members of the healthcare team to help manage glycemic control. Okay, I think that's enough background. Let's move on. To be blunt, most patients with type 2 diabetes may require combination therapy, and that's the focus of today's program. Before we get into the program, Dr. Schaefer, could you please review the Kombiglyze XR contraindications?
Absolutely. First, Kombiglyze XR is contraindicated in patients with renal impairment. For example, serum creatinine levels greater than or equal to 1.5 milligrams per deciliter for men, greater than or equal to 1.4 milligrams per deciliter for women, or abnormal creatinine clearance, which may also result from such conditions as cardiovascular collapse or shock, acute myocardial infarction, and septicemia. It's also contraindicated in patients with hypersensitivity to metformin hydrochloride and patients with acute or chronic metabolic acidosis, including diabetic ketoacidosis. Diabetic ketoacidosis should be treated with insulin.
Thanks, Dr. Schaefer. So, to get started, Dr. Wallem, could you provide us with a quick recap of how Kombiglyze XR works, namely the comprehensive mechanisms of action?
Certainly. So just briefly, as we've already had an overview of the basic pathophysiology of type 2 diabetes, I just want to touch on where and how Kombiglyze XR works. First, gut activity. Lower levels of the incretin hormone glucagon-like peptide 1, also known as GLP-1, are released from the small intestine in patients with type 2 diabetes. Saxagliptin acts by inhibiting DPP-4 enzyme activity, and as a result of this action, incretin concentrations in the bloodstream are increased. Adding to this picture, metformin decreases intestinal glucose absorption. Okay, next is pancreatic activity. Here, saxagliptin decreases glucagon release from the alpha cells in response to increased incretin concentration in the bloodstream, and it also increases insulin release from beta cells in response to increased incretin concentrations in the bloodstream. And while metformin does not alter insulin secretion, it may actually decrease fasting insulin levels and day-long plasma insulin response. Third, we have liver activity. Here, saxagliptin decreases glucose output by the liver in response to a decrease in glucagon release, while metformin decreases glucose activity by the liver. And finally, let's talk about muscle and fat activity. Saxagliptin increases peripheral glucose uptake in response to an increase in insulin release, with metformin improving insulin sensitivity and boosting glucose uptake and utilization.
Thanks, Dr. Wallop. I share your fascination with how these things work. With that being said, let's review a study that assessed the efficacy and safety of saxagliptin versus up-titrated glipizide as add-on therapy to metformin in patients with type 2 diabetes who were inadequately controlled on metformin therapy alone. I suspect we've all seen many patients in that very situation. Dr. Schaefer, will you please describe the study design?
I'd be glad to. Allow me to set the stage. In the clinical studies, saxagliptin plus metformin IR were co-administered as separate tablets. No clinical efficacy or safety studies with Kombiglyze XR have been conducted to date. And I want to emphasize that although a study of the relative bioavailability between Kombiglyze XR and co-administered saxagliptin and metformin IR tablets has not been conducted, bioequivalence between Kombiglyze XR and saxagliptin plus metformin XR taken as separate tablets was demonstrated in healthy adults. All right, so let's take a look at some of the data comparing the efficacy and safety of adding either up-titrated glipizide to metformin IR or saxagliptin to metformin IR, along with diet and exercise. In this head-to-head study, 858 adult patients, all of them with type 2 diabetes, inadequately controlled on metformin alone, were enrolled in a 52-week, multi-center, randomized, double-blind, non-inferiority Phase 3b trial that compared the efficacy and safety of adding saxagliptin versus up-titrated glipizide to metformin IR. Eligible patients were enrolled in a 2-week, single-blind, placebo-controlled lead-in period that included advice on diet and exercise. All enrolled patients had an A1C greater than 6.5 but less than or equal to 10%. Were on a stable metformin dose greater than or equal to 1,500 milligrams a day, and of course this was in addition to diet and exercise. Patients were randomized 1-to-1 to add on saxagliptin 5 milligrams daily or glipizide up-titrated as needed from 5 to 20 milligrams per day. The final mean daily dose of glipizide was 14.7 milligrams per day. The primary efficacy endpoint was to assess non-inferiority in change in A1C from baseline at week 52 achieved with saxagliptin plus metformin IR versus up-titrated glipizide plus metformin IR. Non-inferiority was concluded if the upper limit of the two-sided 95% confidence interval of the difference between treatments was less than 0.35%. Key secondary endpoints in this study included the proportion of patients reporting at least one hypoglycemic event over 52 weeks and the change from baseline in mean body weight at week 52. For the overall study population, the mean baseline A1C was 7.7% for Kombiglyze XR and 7.6% for up-titrated glipizide plus metformin. 858 patients were randomized and treated with double-blind therapy. 633, or 73.8%, completed the 52-week treatment period. Completion rate was 72.9% for saxagliptin plus metformin and 74.7% for up-titrated glipizide plus metformin. The patient population had a mean age of 57.6 years with a mean weight of 88.7 kilograms and a mean BMI of 31.4 kilograms per meter squared. Patients had type 2 diabetes for a mean of 5.4 years. Overall, the demographic and baseline clinical characteristics were well balanced across the treatment groups. All patients in the study received open-label metformin at 1,500, 2,000, 2,500, or 3,000 milligrams daily based on individual metformin dose at the time of enrollment, with the dose remaining stable throughout the study. Patients were randomized to one of two treatment groups and received either saxagliptin 5 milligrams per day plus metformin or glipizide up-titrated as needed from 5 to 20 milligrams daily plus metformin. Glipizide was titrated to an optimal effect or the highest dose tolerated during an 18-week titration period. Finally, the safety and tolerability assessments included adverse reactions, lab values, ECGs, vital signs, and body weight.
Before we get into study results, I'd like to take a minute to review the warnings and precautions for Kombiglyze XR. First, the reported incidence of lactic acidosis in patients receiving metformin is approximately 0.03 cases per 1,000 patient years. When lactic acidosis does occur, it's fatal in approximately 50% of cases. Reported cases of lactic acidosis have occurred primarily in diabetic patients with significant renal insufficiency. I should also note that patients with congestive heart failure, CHF, requiring pharmacologic management, in particular those with unstable or acute CHF who are at risk of hypoperfusion and hypoxemia, are at increased risk of lactic acidosis. Also, lactic acidosis risk increases with the degree of renal dysfunction and patient age. The risk may be significantly decreased, however, by use of the minimum effective dose of metformin and regular monitoring of renal function. Careful renal monitoring is especially important in the elderly, and Kombiglyze XR should not be initiated in patients 80 years of age and older unless measurement of creatinine clearance demonstrates that renal function isn't reduced. Kombiglyze XR should be withheld in the presence of any condition associated with hypoxemia, dehydration, or sepsis. There have been post-marketing reports of acute pancreatitis in some patients taking saxagliptin. With that said, after initiating Kombiglyze XR, you should observe patients carefully for signs and symptoms of pancreatitis. If you suspect pancreatitis, promptly discontinue Kombiglyze XR and initiate appropriate management. It's unknown whether patients with a history of pancreatitis are at increased risk of developing pancreatitis while using Kombiglyze XR. As was mentioned earlier, monitoring renal function is key before initiating Kombiglyze XR, and at least annually thereafter, renal function should be assessed and verified as normal. Kombiglyze XR isn't recommended in patients with hepatic impairment. Metformin may lower vitamin B12 levels, so be sure to measure hematologic parameters annually. And of course, warn patients against excessive alcohol intake. Kombiglyze XR should be suspended for any surgical procedure except for minor procedures not associated with restricted intake of food and fluids. This agent should not be restarted until the patient's oral intake has resumed and renal function is normal.
What can you tell us about hypoglycemia? This is always a topic of concern when treating type 2 diabetes, so I think we should address it.
I agree. When using saxagliptin or metformin with medications known to cause hypoglycemia, there are some things to note. Insulin secretagogues, such as sulfonylureas, cause hypoglycemia. For that reason, a lower dose of the insulin secretagogue may be required to reduce the risk of hypoglycemia if used in combination with saxagliptin, a component of Kombiglyze XR. And while hypoglycemia doesn't occur in patients receiving metformin alone under usual circumstances of use, it could occur when caloric intake is deficient, when strenuous exercise is not compensated by caloric supplementation, during concomitant use with other glucose-lowering agents such as sulfonylureas or insulin, or with use of ethanol. Let me point out that elderly, debilitated, or malnourished patients and those with adrenal or pituitary insufficiency or alcohol intoxication are particularly susceptible to hypoglycemic effects. This point was briefly touched on before. Intravascular contrast studies with iodinated materials can lead to alteration of renal function, and they've been associated with lactic acidosis in patients receiving metformin. Kombiglyze XR should be temporarily discontinued at the time of or prior to the procedure and withheld for 48 hours after the procedure and reinstituted only after renal function is normal. There have also been post-marketing reports of serious hypersensitivity reactions in patients treated with saxagliptin, including anaphylaxis, angioedema, and exfoliative skin conditions. Onset of these reactions occurred within the first 3 months after initiation of treatment with saxagliptin, with some reports occurring after the very first dose. If a serious hypersensitivity reaction is suspected, discontinue Kombiglyze XR, assess for other potential causes for the event, and institute alternative treatment for diabetes. And finally, there have been no clinical studies establishing conclusive evidence of macrovascular risk reduction with Kombiglyze XR or any other anti-diabetic drug.
Thank you, Dr. Steinberg. It's important to review the safety information as we move through this program. We know there's more to come. Now, let's look at the results of the head-to-head non-inferiority study. Dr. Wallem, you're up.
Great, I'm ready. As you can see, for adult patients with type 2 diabetes inadequately controlled on metformin alone, saxagliptin 5 mg plus metformin immediate release was non-inferior to up-titrated glipizide added to metformin IR in lowering A1C from baseline to week 52. The upper limit of the 95% confidence interval met the predefined criterion for non-inferiority of less than 0.35%. Thus, saxagliptin 5 mg plus metformin IR was non-inferior to up-titrated glipizide plus metformin IR. The adjusted mean change in A1C from baseline to week 52 was a 0.6% reduction in the saxagliptin 5 mg plus metformin IR group on the left, and on the right we see a 0.7% reduction in the up-titrated glipizide plus metformin IR group.
I'm going to interrupt for a second, Dr. Wallem.
Please, go ahead.
It's important to note that non-inferiority of saxagliptin to up-titrated glipizide may be limited to patients with a baseline A1C of below 9%, as 91% of patients in that trial had this value.
That's right, Dr. Mintz. Thank you. To continue, I'd like to point to the discontinuation rate due to a lack of efficacy. The proportions of patients who discontinued because of a lack of efficacy by week 52 in the saxagliptin 5 mg plus metformin IR group was 15.3% and 12% in the up-titrated glipizide plus metformin IR group.
Thanks, Dr. Wallem. I find non-inferiority an interesting and important concept when discussing clinical trials and treatment options. Continuing to focus on the clinical trial, let's review the safety results. There's a lot to cover in this section. I know safety is always a key concern for physicians and patients, and since hypoglycemia is of particular interest, let's start by taking a look at the rates of hypoglycemia during the 52-week study period. These are the rates of hypoglycemia in both saxagliptin 5 mg plus metformin IR and up-titrated glipizide plus metformin IR treatment arms. Compared with up-titrated glipizide added to metformin IR, saxagliptin 5 mg plus metformin IR resulted in a lower proportion of patients who experienced hypoglycemia. A total of 13 patients, which is 3%, on saxagliptin 5 mg plus metformin IR versus 156 patients, which is 36.3%, on up-titrated glipizide plus metformin IR reported hypoglycemic events. No patients, or 0% on saxagliptin plus metformin IR, had confirmed hypoglycemic events, defined as a glucose of less than or equal to 50 milligrams per deciliter with associated symptoms, versus 35 patients, or 8.1% of the glipizide plus metformin IR patients. Now, let's examine the change in weight. Change in weight is a concern for many of my patients with type 2 diabetes. Here we see that patients treated with saxagliptin 5 mg plus metformin IR experienced statistically significant body weight reduction versus titrated glipizide added to metformin IR. There was a mean reduction of 2.4 pounds in body weight in the saxagliptin 5 mg plus metformin IR group versus a mean increase of 2.4 pounds in the body weight in the glipizide plus metformin IR group from a baseline mean body weight of 196 pounds in each treatment arm. This is important data in two areas of key concern: hypoglycemia and weight issues. Let's discuss dosing and administration. Kombiglyze XR is a once-a-day metformin XR with a DPP-4 inhibitor combination tablet, and I think it's worth going over some details. Dr. Steinberg, would you review this for us?
I'd be happy to. Understanding dosing and administration is always very important. Kombiglyze XR provides the convenience of once-a-day dosing. For treatment-naive patients, you can start with saxagliptin 5 mg, metformin XR 500 mg once a day. Then you can up-titrate to the saxagliptin 5 mg, metformin XR 1000 mg based on tolerability and glycemic control. In my practice, I usually start with the 500 mg dose and then up-titrate to the 1000 mg dose as tolerated. Kombiglyze XR should generally be administered once daily with the evening meal with gradual dose titration to reduce the gastrointestinal adverse effects associated with metformin. For patients who are uncontrolled on metformin monotherapy, the starting dose should match the dose of metformin that they're already taking, or the nearest therapeutically appropriate dose. Patients who need 2.5 milligrams saxagliptin may be treated with Kombiglyze XR 2.5 milligram 1000 milligram metformin. If they are metformin naive or require a higher dose of metformin, individual components should be used. The maximum recommended daily dose is saxagliptin 5 mg and metformin XR 2000 mg, which can be taken as 2.5 mg 1000 mg tablets once a day. Back to you, Dr. Mintz.
Let me add a few points. First of all, you'll need to monitor glycemic control in patients who are switching from metformin IR to metformin XR and make your dosage adjustments accordingly. Second, Kombiglyze XR should be swallowed whole and not crushed, cut, or chewed. Here are some final dosing considerations. Because ketoconazole, a strong CYP3A45 inhibitor, increases saxagliptin exposure, when prescribing, you want to limit the dose of Kombiglyze XR to 2.5 milligrams 1000 milligrams once daily for patients who are taking any type of strong CYP3A45 inhibitor, such as atazanavir, clarithromycin, indinavir, itraconazole, ketoconazole, nifazodone, nalfinavir, ritonavir, sequinavir, or telithromycin. Also, cationic drugs eliminated by the renal tubular secretion may reduce metformin elimination and should be used cautiously. It's important to note that Kombiglyze XR has not been studied in pregnant and nursing women. It should only be used during pregnancy if clearly needed. Because it isn't known whether saxagliptin or metformin is secreted in human milk, caution should be exercised when Kombiglyze XR is administered to a nursing woman. In addition, there are no clinical trial data in pediatric patients. Next, we'll review the adverse events data from key studies in which metformin and/or saxagliptin were evaluated. This will add the final piece of information about Kombiglyze XR that we'll be presenting today. And of course, it's important information we use to make informed treatment decisions. Dr. Wallam, are you ready for your final comments?
Yes, I certainly am. Let's take a look at the adverse reactions associated with metformin XR versus placebo. The most commonly seen in placebo-controlled clinical trials reported in over 5% of patients treated with metformin XR, and more commonly than in placebo-treated patients included diarrhea, 9.6 versus 2.6%, and nausea and/or vomiting, 6.5 versus 1.5%. Diarrhea led to discontinuation of study medications in 0.6% of patients treated with metformin XR. To put this information into perspective, this table shows the rates of hypoglycemia over 6 months for both the treatment-naive and uncontrolled on metformin monotherapy populations. The incidence of reported hypoglycemia in phase 3 registrational trials in patients uncontrolled on metformin monotherapy were 7.8% for saxagliptin 2.5 milligram plus metformin, 5.8% for saxagliptin 5 milligram plus metformin, and 5% for placebo. For treatment-naive patients, the incidence of hypoglycemia was 3.4% in the saxagliptin 5 milligram plus metformin group, compared with 4% in the metformin monotherapy group. Here we can see a pooled analysis of the incidence of adverse events in 5 clinical trials with saxagliptin. The most common adverse events occurring in 5% or more of patients in the saxagliptin 5 milligram arm, and more commonly than placebo, were upper respiratory infection, 7.7 versus 7.6%, urinary tract infection, 6.8 versus 6.1%, and headache, 6.5 versus 5.9%. In patients treated with saxagliptin 2.5 milligram, headache, 6.5%, was the only adverse reaction occurring in 5% or more of patients, and more commonly than with placebo. Also in this pooled analysis, adverse reactions reported in 2% or greater of patients treated with saxagliptin 5 milligram or saxagliptin 2.5 milligram, and 1% more frequently compared to placebo, respectively, included sinusitis 2.6 and 2.9% versus 1.6%, abdominal pain 1.7 and 2.4% versus 0.5%, gastroenteritis 2.3 and 1.9% versus 0.9%, and vomiting 2.3 and 2.2% versus 1.3%. Now, this next table shows the incidence of adverse events in 5% or more of the treatment-naive patients who received saxagliptin 5 milligrams plus metformin IR. These adverse events occurred more commonly in the saxagliptin-treated group compared to the control group. Incidence of headache was higher in the saxagliptin plus metformin group, 7.5 versus 5.2%, and nasopharyngitis was 6.9 versus 4% of patients. And note that decrease in body weight with Kombiglyze XR was similar to that of metformin IR alone. And shown in this table is the incidence of diarrhea over 6 months for the treatment-naive and uncontrolled metformin monotherapy groups. Looking at the first and last columns, the incidence of diarrhea was seen across both studies. Finally, I want to briefly review one last bit of safety information. As you can see, the rates of discontinuation due to adverse events were 3.3% in patients treated with saxagliptin 5 milligram, 2.2% for patients treated with saxagliptin 2.5 milligram, and 1.8% for patients treated with placebo. The table shows us that the most common adverse events leading to discontinuation were lymphopenia, rash, increased blood creatinine, and increased blood creatinine phosphokinase. Hypersensitivity-related events such as urticaria or facial edema were reported in 1.5, 1.5, and 0.4% of patients who received saxagliptin 5 mg, saxagliptin 2.5 mg, and placebo, respectively. Although causality has not been established, there were 6 cases of tuberculosis reported among saxagliptin-treated patients compared with no reports for comparator-treated patients. None were from the United States or Western Europe, and there have not been any spontaneous reports of tuberculosis with saxagliptin use. In addition, there was a dose-related mean decrease in absolute lymphocyte count observed with saxagliptin.
Thanks, Dr. Wellham. Our viewers should now have a good understanding of the important safety information for Kombiglyze XR. Let me conclude this program by first thanking our faculty. Doctors, thank you. And also thanking you, our audience, for your interest in this important topic. Clearly, it's an ongoing struggle for many patients with type 2 diabetes to achieve adequate glycemic control. The pathophysiology of this disease almost assures that most patients will eventually require combination therapy. The non-inferiority trial data we've reviewed today illustrates that the clinical use of Kombiglyze XR in adult patients with type 2 diabetes when treatment with both saxagliptin and metformin may be appropriate in certain patients. I hope you find Kombiglyze XR to be an effective treatment option for adults with type 2 diabetes in addition to diet and exercise when treatment with both saxagliptin and metformin is appropriate. Thank you again for your interest in our program. Goodbye.